Today we are discussing anemia in pregnancy. So, anemia is a clinical feature and it is not a disease. In India, incidence of anemia is around 40 to 90%, and it is directly responsible for 20% of maternal deaths, and it is indirectly for further 20%. So, maternal mortality is caused by 20%. 20% of maternal mortality is due to anemia. Inadequate food intake is the most common reason, and average caloric intake of Indian women is 1400 to 1800 kilocalories. So what is normal erythropoiesis? The requirement for normal erythropoiesis is active bone marrow, erythropoietin, iron and traces of copper, folic acid for synthesis of purines and pyrimidines, that is nucleotides for the DNA synthesis, and vitamin C for conversion of folic acid to active form folic acid and nucleoproteins. So what is normal erythropoiesis? In erythroblast converts into pronormoblast and it converts into basophilic normoblast. Till basophilic normoblast, there is no requirement of any hemoglobin, that is iron is not required. And later for formation of polychromatic normoblast, epipnotic normoblast, reticulocyte and erythrocyte, iron is required. So in iron deficient state, microcytic and hypochromic erythrocytes are formed. In abnormal erythropoiesis, erythroblast converts into megaloblast due to deficiency of folate or vitamin B12, that is macrocytic anemia, megaloblastic anemia, and it forms a large reticulocyte and it converts into macrocyte, whereas in iron deficiency anemia, microcyte is formed. Definition: anemia is defined as hemoglobin value, the threshold hemoglobin value of 2 standard deviations below the median value of a healthy matched population. This is the standard definition. Or it can also be defined as a state in which hemoglobin is below the normal range for the individual's age, sex and altitude of residence. So there are various classifications. According to Community for Disease Control, anemia in pregnancy is classified as: in first trimester, hemoglobin less than 11 gram per deciliter, second trimester it is less than 10.5, and in third trimester it is 11. In second trimester the value is lowered because of hemodilution. There will be normal physiological anemia. And according to WHO, if it is less than 10.5 gram per deciliter, it is defined as anemia. In our population, we are iron deficient state, will be in iron deficient state. So in India, if it is less than 10 gram per deciliter, it is defined as anemia. So what is classification? Classification based upon the etiology. It is they are nutritional anemias, hemoglobinopathies, hemolytic anemias, aplastic anemias, and anemia due to blood loss. In nutritional anemia, that is iron deficiency, folate deficiency, and B12 deficiency. And hemoglobinopathies are sickle cell disorders where HBSS will be formed, and beta and alpha thalassemia syndromes. And hemolytic anemias, that is RBC membrane disorders, RBC metabolism disorders, and autoimmune conditions. And aplastic and anemia due to blood loss. So based upon the degree of severity, anemia may be classified as mild, moderate, and severe. Mild, that is 8 to 10 gram per deciliter, and moderate is 6.5 to 8, and severe is less than 6.5 gram per deciliter. So causes of anemia in pregnancy. Nutritional cause is the most common cause of anemia in India and in most parts of the world, and parasitic infestation such as hookworm infestation accounts to 25 to 35%, and chronic blood loss as in hemorrhoids, that is 5 to 7%, and in hemoglobinopathies, that is sickle cell disorders and thalassemias. So what are the symptoms of anemia? That is lassitude, fatigue, breathlessness, palpitations, dizziness, tinnitus, headache and dimness of vision, insomnia, angina, paresthesias, irritability, and poor memory and muscle ache. There will be generalized symptoms like easy fatigability and lassitude. Breathlessness might be because of pulmonary edema, and palpitations because of cardiac overload. Dizziness and tinnitus because of hypoxemia. Headache might also be because of hypoxia. Insomnia might be present. Angina, chest pain might be because of cardiac overload, and generalized neurological symptoms like paresthesia, irritability, poor memory, and muscle ache might also be present. So what are signs of anemia? Signs are skin pallor. Pallor might be seen on skin and on the mucous membrane. Mucous membrane, that is conjunctiva, and on the tongue and palms. So pallor might be seen even on the palms and conjunctiva. That is lower palpebral conjunctiva is usually observed. And tachycardia might be present because of cardiac overload, and systolic flow murmurs, ejection systolic murmur might be present, and cardiac dilatation and edema might be present. Edema might be because of hyperproteinemia in association with anemia. So now we will discuss iron deficiency anemia. Iron deficiency is the most common cause of anemia in pregnancy. The worldwide incidence is 51%. Iron is present in all cells of the body, and iron is required for transportation of oxygen and cytochromes. So iron metabolism, this is important because this is frequently asked for you. Iron metabolism and folic acid are frequently asked. So what is the total body iron in a woman is 2 grams or 2.3 grams. 80% of the total body iron is in RBC mass as hemoglobin, and iron not in use is stored in as soluble protein complex called as ferritin and also as hemosiderin. 2/3 is stored as ferritin and 1/3 is stored as hemosiderin, and ferritin is stored in liver, spleen, muscle and bone marrow. So normal absorption mechanism in a gastrointestinal system is required to maintain the balance between functional and stored iron. Our functional iron is in the form of hemoglobin and enzymes, and stored iron is in the form of ferritin and hemosiderin. So factors controlling iron absorption are amount of stored iron and type of iron in the diet. Normally only 10% of the dietary iron is absorbed. So now we will see the pathway of iron absorption. So dietary iron, heme iron, and there are 2 forms of iron in the diet, that is heme iron and non-heme iron. Heme iron is usually from animal source. Heme iron is usually from animal source, which accounts for about 10% of the total dietary iron in our population, and non-heme iron is about more than 90%. So 30% of heme iron is absorbed by the body, and 5% of non-heme iron is absorbed by the body. So the factors which increase the amount of absorption are amino acids and vitamin C. So if iron tablets are taken along with citric acid or any fruit juice, absorption of iron will be increased. And those which inhibit the inhibitory factors for iron absorption are phytates, tannins and phosphates. So iron is absorbed from the gastrointestinal mucous membrane. So hypoxia, anemia, hypoxia and low iron stores increase the absorption capacity of iron. So iron is absorbed in ferric form, that is Fe+3, and it is stored as ferritin, or it may be transferred via transferrin. Transferrin helps in transfer of iron from the gastrointestinal mucosa via blood to the tissues. So in tissues, iron may be stored as ferritin, that is storage form, or as functional form. It may be utilized in enzymes or myoglobin or hemoglobin. Let us see the flow chart. So in intestinal lumen, iron from the food, that is, it is in the ferrous form, Fe+, is converted into ferric form, and it is transferred as ferritin, and it might be stored in the cells in the gastrointestinal mucosa, and it is shed by exfoliation of the gastrointestinal mucosa, or via transferrin from mucosal transport protein. It is transferred into transferrin. Transferrin transfers it to the tissue receptors, and it might be in the form of a functional iron or storage iron. Functional iron is hemoglobin, enzymes and myoglobin, and storage form is ferritin, hemoglobin and hemosiderin. So what is the control of absorption of iron by the intestinal mucosa? Not that all the iron what present in the diet is being absorbed. So the absorption of iron is being controlled by various factors. So if body iron stores are deficient, so the loss of iron will be less, and the intake of iron, absorption of iron will be more. So iron that is lost will be less. Iron that is lost is through the sloughed gastrointestinal mucosa and other skin cells. This will be less, and the iron absorption rate will be more. If iron is overloaded, as in case of sickle cell anemia, then absorption of iron will be decreased, and the iron lost from the body will also be increased. So average iron requirement is, in an adult male it is 1 milligram per day. In a woman of reproductive age, that is menstruating woman where menstrual blood loss is more, she requires 2 milligrams per day, and in early pregnancy it is 2.5 milligram per day. In late pregnancy it is 7 milligram per day, and in average requirement is 4 milligram per day. So the average diet should contain 50 milligrams of iron, of which only 10% is absorbed. So total iron requirement during pregnancy, this is important. So the total iron required by the fetus takes around 300 milligram of the iron, and placenta and the blood loss at delivery. So the placenta and the blood loss at delivery is totally around 300. So 300 is for the fetus, and 300 is for placenta and puerperium, that is 250. And RBC mass, the RBC volume, the hemodynamics change in pregnancy. So the RBC mass increases during pregnancy. So RBC mass, the total required for improvement of RBC mass is around 450 milligrams. That is, this is mostly required during late trimester, last trimester of pregnancy. And the basal losses, that is lost through the skin, epithelium, gut, mucosa, the etc. Counts to around 220 milligram. So 300 is for the fetus, 300 is for placenta and puerperium, and 450 is for the RBC mass, and 220 is for basal losses. So the total iron required is 1270 milligrams, and 200 milligram is required during lactation. So iron is lost even during lactation. So 200 milligram is required. So total of around 1470 milligram of iron is required during pregnancy. So what do we save during pregnancy? Because of cessation of periods, that is no iron is lost during menstruation. So 270 milligram of iron stores will be present, and because of contraction of blood volume, 130 milligram is present. So total savings of 400 milligrams. So the total iron required is around 1000 milligram. So for the total iron requirement during pregnancy is around 1000 milligram. So what are the dietary sources of iron? Heme iron. Heme iron is from the animal proteins, that is muscle, meat, organ meat, fish and shellfish. And non-heme iron are peas, beans, nuts, dry fruits, and wholemeal bread and chocolate. Causes of iron deficiency, anemia in pregnancy. Might be because of inadequate diet, that is diet rich in phytates and tannins, and increased blood loss as in hookworm infestation, and gastrointestinal bleeding, that is because of gastrointestinal ulcers or hemorrhoids, or because of any acute blood loss as in cases of threatened abortions, etc., or because of malabsorption syndromes, that is Crohn's disease, ulcerative colitis. And normal values. So what are the normal values? Normal RBC count is around 3.2 to 5 million per cubic millimeter, and hemoglobin is 12 to 14 gram per deciliter. In pregnancy, 10 is normal, and in reticulocyte count is 0.2%, packed cell volume 37 to 42%, mean corpuscular volume is 78 to 92 micrometer cube, and mean corpuscular hemoglobin concentration is 27 to 32 picograms. Mean corpuscular hemoglobin concentration is 28 to 34%. Total serum iron is 60 to 160, and serum ferritin is 40 to 160. TIBC is 300 to 360. So transferrin saturation is always maintained at 35 to 50%. What is pathophysiology? Not that anemia develops acutely. There are 3 stages of development of anemia. So in the first stage, all the iron stores are depleted. So all the iron stores, what we know of are ferritin and hemosiderin. And first low serum ferritin occurs, and hemosiderin might be absent. And in second stage, there will be abnormal physiology. So low serum iron will be present, low transferrin, and high TIBC will be present. Increase in RBC protoporphyrin will be present. So in third stage, that is what we see in clinical features, that is frank anemia is present. That is low hemoglobin, microcytosis, and hypochromasia. So what are the effects of iron deficiency? In presence of iron deficiency, iron-dependent enzymes in the cells are affected. So the effects on the body functions are impaired muscle function. So what we see is myalgia, impaired neurotransmission, that is paresthesias might be present, irritability might be present, and decreased exercise tolerance, that's myalgia, easy fatigability will be present, and epithelial changes. What are the epithelial changes we see of our glossitis and stomatitis? Altered gastrointestinal function will be present. So what are the effects of anemia on mother? Antenatal effects are preterm delivery and high output failure. High output cardiac failure might be present, and during labor, second stage of labor, congestive cardiac failure might be present, and postpartum hemorrhage might be present. And in postpartum period, because of anemia, infection, poor wound healing, failure of lactation, and postnatal depression might be present. So the fetus is usually not affected by anemia. The fetus obtains iron from maternal transferrin regardless of the maternal iron stores. So it is usually not affected. The placenta traps maternal transferrin, removes iron and actively transport it to the fetus mainly in the last 4 weeks of pregnancy. So most of the iron found in fetal hemoglobin, but 1/3 is stored in the fetal liver. So only in severe stages of anemia will the fetus be affected, but it is usually not affected because it is not dependent upon the iron stores. It is dependent only upon the transferrin present upon in the mother. So iron deficiency, if frank iron depletion occurs, what are the fetal risks? Are iron deficiency anemia might be present in infancy of the baby, and delay in the development of milestones, behavioral abnormalities and cognitive functions might be there, and higher incidence of IUGR, it may lead to adult cardiovascular diseases, and high incidence of prematurity might be present. So what are the specific clinical features what we see in anemia? That is ankylostomatitis and glossitis because of epithelial shedding, defective epithelial shedding, and platinichia and koilonychia might be seen. Koilonychia are spoon-shaped nails, and post-recoil web might be seen. Plummer-Vinson syndrome and sideropenic dysphagia might be present. This is ankylostomatitis at the angles of the mouth. This is glossitis. This is koilonychia, spoon-shaped nails, and this is post-cricoid web. So what are the clinical features? Soft ejection systolic murmur because of cardiac overload, and pallor of the skin and the mucous membrane might be present. Edema, platinichia, koilonychia, glossitis, stomatitis, and tachycardia. What are the investigations we do? That is hemoglobin and hematocrit, red cell indices, peripheral blood smear, and serum ferritin are observed. So what are the diagnostic features for iron deficiency anemia? Hemoglobin might be variable. Hemoglobin might be variable because it presents only in frank anemia. And in stage 1 and stage 2, hemoglobin will be normal, and mean corpuscular volume will be reduced. That is microcytosis is present. RBC count might be normal or reduced. WBCs and platelets are not affected. And transferrin is increased because it is a receptor for carrying iron. So transferrin and plasma transferrin receptors are increased, and plasma iron, serum ferritin, and bone marrow iron, all these are reduced. And zinc protoporphyrin will be increased. So hemoglobin might be variable, mean corpuscular volume will be reduced, RBC count is normal or reduced, WBC platelets not affected, transferrin and transferrin receptors are increased, and serum ferritin, plasma iron, and bone marrow iron are reduced. What is on peripheral blood smear in iron deficiency, we see for microcytosis, that is small RBCs, and hypochromia, low pigmentation of the RBC because of defective hemoglobin, less hemoglobin formation, and oval and elliptical cells are seen, poikilocytes may be seen. Management. So oral dose of elemental iron required to treat iron deficiency is 100 to 200 milligrams per day. What we give is ferrous sulfate, 200 milligrams thrice a day is given, 3 times a day is given, and it is equivalent to 195 milligrams of elemental iron. That is, in each tablet of in each 200 milligram of ferrous sulfate tablet, 60 milligram of elemental iron is present. So it equals to 195 milligram of elemental iron if given thrice daily. So total dose of iron required should contain this is the treatment dose. So treatment dose of iron should continue till hemoglobin level normalizes. Once the hemoglobin is normalized, then we will give prophylactic or maintenance dose. Prophylactic dose is 30 milligram of elemental iron per day for 3 months postpartum. This is given to replenish the iron stores. So the treatment dose is 200 milligram thrice daily till the hemoglobin level normalizes. And once the hemoglobin is normalized, prophylactic or maintenance dose of 30 milligrams of elemental iron per day for 3 months to replenish the iron stores present in the body. So how do we take oral iron? It should not be taken along with meals and should be taken 1 hour after meals, along with some fruit juice that is containing vitamin C, which increases the absorption. If taken with meals, absorption is reduced by 50%. So what are the side effects of oral iron? That is ferrous sulfate. Nausea, epigastric discomfort, altered bowel habits, and abdominal cramping. Abdominal cramping. Other oral iron preparations available are ferrous gluconate, succinate, and fumarate. So what we see is ferrous sulfate, ferrous gluconate, succinate, and fumarate. These are the oral iron preparations available. So what are inhibitors of iron absorption? That is tannins and calcium. That is tannins present in tea and calcium. So it should not be taken along with milk and tea. And phytates and polyphenols. Phytates and polyphenols, they are present in plants. So it should not be taken along with food. So how do we monitor our treatment? Response to treatment of elemental iron is very rapid, and reticulocyte count increases in 5 to 10 days. So reticulocyte count is 0.2%, and it is the first hematological evidence that we see. That is, it increases 5 to 10 days, within 5 to 10 days of oral iron treatment. And rise in hemoglobin occurs at the rate of 0.8 gram per deciliter per week. If there is no clinical or hematological response observed in 3 to 4 weeks, diagnostic re-evaluation should be done, and we have to confirm the compliance of the patient for oral iron intake, and we should exclude any blood loss. So response of the treatment, these are the laboratory monitoring what we do for response, and immediately within first 3 days of treatment, patient shows well-being of the patient will be present. That is, patient loses lassitude, myalgia, fatigue, irritability, all this will be lost, and the earliest clinical improvement is seen in iron deficiency anemia. So indications for parental iron transfusion. Parental is, that is, we give either by intramuscular or intravenous, and diagnosis of iron deficiency anemia should be established. That is, other causes of anemia should be ruled out, and if oral iron is not tolerated or not absorbed, or there is non-compliance of the patient to oral iron therapy, we can give parental iron. And if the period of gestation is more than 32 weeks and hemoglobin is less than 7.5 gram per deciliter, we can't wait for oral iron for improvement. We have to give parental iron. So what are the available formulations? That is iron dextran, iron sorbitol, and iron sucrose. Iron sorbitol could be given only intramuscularly, whereas iron dextran and iron sucrose could be given either intramuscularly or intravenously. And other form which is available is ferric carboxymaltose. That is ferric carboxymaltose. It could be given intravenously in a dilutional form. So total parental treatment. Iron could be, so the total dose of iron required to give parentally must be calculated. So the two formulae are available. One is 2.4 into weight of the patient in kilograms into D. D is normal hemoglobin, that is expected hemoglobin, that is 12 to 14, minus patient's hemoglobin plus 1000 milligrams. These 1000 milligrams are for the iron stores, and this is for improvement of hemoglobin, that is 2.4 into weight of the patient in kilograms into normal hemoglobin minus patient's hemoglobin total plus 1000 milligrams, or it could be weight in pounds into 0.3 into 100 minus hemoglobin in percentage. This second formula is usually used for iron dextran. So total dose infusion, that is the total dose of iron required, calculated iron required could be given at intervals, or it could be infused intravenously at a time in a single day. That is total dose infusion. It is given only intravenously. Total dose infusion is not available for intramuscular. So the compound used is iron dextrose or iron sucrose. It is safe, effective, and less side effects are present. So estimation of total dose is iron dextran 0.3 into weight into 100 minus hemoglobin percentage plus 50%, and iron sucrose is 2.3 into weight into D is the difference, that is target hemoglobin minus patient hemoglobin plus 1000 is the dose which we usually use, and infuse. So what we do is we'll add iron sucrose ampules in 100 ml of NS solution, and we will run it over 15 minutes, and we have to stop the transfusion if there are any adverse effects. So what are advantages of intravenous route? Intravenous route advantages are it eliminates repeated and painful intramuscular injections, and treatment is completed in a day, and patient will be discharged much earlier from the hospital. It is less costly compared to that of repeated intramuscular therapy. So what are limitations? Limitations is, as the maximum, we are giving transfusing only iron. We are not transfusing any hemoglobin. So it takes time for the hemoglobin to develop. So as the maximum hemoglobin response does not appear before 4 to 9 weeks. So it takes 4 to 9 weeks for the blood, for the hemoglobin to increase after transfusing iron intramuscularly or intravenously. So the method is unsustainable if there is at least 4 weeks time, if at least 4 weeks time is not available. So if the patient gestational age is more than 32 weeks and less than 36 weeks, only then we can give iron sucrose for improvement of hemoglobin. If the patient's gestational age is more than 36 weeks, we can't give intravenous hemoglobin for iron improvement because she is near term. And previous history of reaction of any parenteral therapy, iron sucrose should not be given. So intramuscular iron therapy, how we give is 1 ml test dose is given and 2 ml 100 milligram injection with 2-inch deep IM needle it is given, and jet technique is followed. First we will inject saline or aid before withdrawing the needle from the buttocks. And role of blood transfusion. So consider blood transfusion when period of gestation is more than 36 weeks and hemoglobin is less than 75 gram per deciliter. So here, if the period of gestation, if the patient is with anemia and POG is more than 36 weeks, there is no role for parenteral iron, that is intravascular or intravenous or intramuscular iron is not useful because it takes 4 to 9 weeks for the hemoglobin to improve. And if there is any refractory anemia, that is it is not getting corrected with oral or parenteral iron, or anemia due to any blood loss, that is APH or PPH, and in partial exchange transfusion if the patient is in congestive cardiac failure. What are the advantages? It increases the oxygen carrying capacity of blood and it stimulates erythropoietic. Erythropoietic factors may be present in the blood we transfuse, so it stimulates erythropoiesis. Hemoglobin from the hemolyzed red cells may be utilized for the formation of new red cells, and it supplies the natural constituents of blood like proteins, clotting factors, and antibodies. And improvement is expected after 3 days. So what are the drawbacks of blood transfusion? That is, it may precipitate preterm labor, and congestive cardiac failure might be precipitated because of cardiac overload. It may present as pulmonary edema because of left heart failure, and transfusion reactions may occur. So in such cases, we may plan for exchange transfusion. So what are the indications? That is cardiac failure due to severe anemia, and cases of severe anemia requiring surgery. Severe anemia, whether whatever may be the type, near term as a safer alternative to simple transfusion. So in any cases where there is where we expect cardiac overload because of our blood transfusion, we will be around 350 ml of blood. So we will giving 350 ml of fluid, and the workload on the heart is increased. In such cases, we may plan for exchange transfusion. So what are the drawbacks? Drawbacks are large quantity of fresh blood is required, and that too has to be collected from the several donors, and the chance of serum hepatitis is more. So how do we manage the anemia, iron deficiency anemia, anemic patient during labor? Patient should be kept in a comfortable position, that is propped up position. Usually what we what we advise throughout the pregnancy is patient should be asked to lie in left lateral position to prevent pressure upon the inferior vena cava. And here during labor, we will ask her to sit in a comfortable position or in a propped up position, and that is with 45 degrees inclination from the bottom. And oxygen inhalation must be present to prevent cardiac overload, and adequate analgesia must be given. And strict asepsis should be followed as she is prone for infections, and prophylactic outlet or forceps or assisted delivery may be planned. And we should withhold injection ergometrin. Ergometrin is a vasoconstrictor which increases the cardiac overload. So ergometrin might be withheld, and prophylactic antibiotic should be given because there are chances of infection. So during second stage of labor, strict asepsis should be followed, and prophylactic low forceps or vacuum delivery may be done to shorten the duration of second stage of labor. So it is a question for you, it is commonly asked. So where do you cut short the second stage of labor? It is usually done in cases where there is where heart diseases are present. So in such conditions, overload on the heart will be more during second stage of labor because peripheral pumping from the periphery blood is pumped more towards the heart. So in such conditions, second stage must be cut short. So it is usually around 30 minutes, and we have to cut short the second stage of labor. And anemia is one of the cause. Intravenous methotrexate should not be given following delivery. And in third stage of labor, we should be very vigilant during third stage because PPH may occur. Because along with anemia, not only iron deficiency, coagulation factor deficiency because of protein deficiency might also be present. So one should be very vigilant during the third stage, and significant amount of blood loss should be replenished by fresh packed cell transfusion after taking usual precautions mentioned earlier. And the danger of postpartum overloading of the heart should also be considered. During puerperium, as there is chance of infection and poor wound healing, prophylactic antibiotics should be given, and look for any sepsis and subinvolution of the uterus, any failing lactation. So because of anemia, there might be subinvolution of uterus, and lactational failure might be present, congestive cardiac failure and pulmonary embolism might be present. So continue anti-anemic therapy till normal clinical and hematological state. Even in normal state, continue iron therapy for 3 months. So warn about the risk of recurrence and counsel about diet spacing. Birth spacing, it is usually 2 years must be present to prevent any nutritional deficiency anemia. And during spacing, we have to advise contraception. Please recheck the hemoglobin level before discharge of the patient. So what is CSSM program? That is Child Survival and Safe Motherhood Program, in which the ASHA worker or the ANM gives 100 tablets to the patient during the second and third trimester of pregnancy, and ask the patient to take 1 tablet daily. So each tablet contains 100 milligrams of iron and 5 milligrams of folic acid. This is used to prevent nutritional anemia. So now we will discuss megaloblastic anemia. So what is megaloblastic anemia? It may occur because of deficiency of folic acid or vitamin B12. In pregnancy, folic acid deficiency is the common cause of megaloblastic anemia. Folic acid is required for synthesis of, as we see, purines and pyrimidines. These are the nucleotides which are useful in DNA synthesis, and the absence of which leads to defect in DNA synthesis. So folic acid deficiency is the most common cause in pregnancy, and vitamin B12 deficiency in pregnancy is very rare because vitamin B12 is usually stored in the body, but folic acid is water soluble and it is usually lost. So folic acid, what is the requirement? Requirement of folic acid in non-pregnant state is 50 to 100 micrograms per day, and in pregnancy is 400 micrograms per day. So what is the source of folic acid? That is green leafy vegetables, legumes, meat and rice. It is mainly stored in the liver, and folic acid helps to build DNA and proteins in all tissues, including fetus, placenta, RBC mass, uterus, etc. So folate metabolism. So folic acid is used to increase the 1-carbon donor pool. This 1-carbon donor pool is the pool which donates methyl group. That is CH3 groups are donated to various metabolic pathways, among which from which purines and pyrimidines can be formed. So purines and pyrimidines are useful in the formation of nucleic acids, nucleotides. So it helps in donation, it helps in formation of tetrahydrofolate, which forms the 1-carbon pool which donates methyl group, that is CH3 group, which helps in formation of purines and pyrimidines. So folate deficiency at cellular level, folic acid is reduced to folic acid is reduced to dihydrofolic acid and then to tetrahydrofolic acid, which is required for cell growth and division. So more active is the tissue reproduction and growth. More it is dependent on supply of folic acid. That is, so more active tissues are more dependent on folic acid. So what are the more active tissues? Bone marrow and epithelial lining are the most active tissues. Folate requirement increases in pregnancy to meet the needs of fetus, placenta, uterine hypertrophy and expanded RBC mass. So causes. So what are the causes of folic acid deficiency? Poor dietary intake, excessive alcohol intake and increased cell turnover as in pregnancy, and in pregnancy also increased cell turnover is seen in multiple pregnancy, and in renal losses of folic acid, that is congestive renal failure, malabsorption disorders, drug induced anticonvulsants and methotrexate. So methotrexate is an anti-cancer drug. So when we give methotrexate, we have to give folic acid or folic acid along with it, and decreased storage. Decreased storage, it is stored in liver. So hepatic disorders and hyperhomocysteine, and in vitamin C deficiency, decreased storage occurs. In vitamin C deficiency, storage decreases because folic acid is converted into active form folic acid in the presence of vitamin C. So if vitamin C is deficient, folic acid absorption is poor. So pathophysiology. The earliest biochemical evidence is low plasma folate levels. It occurs within 3 weeks. If 3 weeks of dietary deficiency of folic acid. If there is 3 weeks of dietary deficiency of folic acid, then first the affected is low plasma folate levels. So the earliest morphological change what we see in folic acid deficiency is hypersegmented neutrophils. These occur in 5 weeks of nutritional deficiency, and the appearance of macrocytes and megaloblastic bone marrow occurs after 17 weeks of folic acid dietary deficiency. In severe cases, both WBC and platelets, megakaryocytes might be affected, and we see leukopenia and thrombocytopenia. So what is the laboratory features we see? Red cell indices, these are macrocytes will be formed. That is, mean corpuscular volume will be increased more than 100. Mean corpuscular hemoglobin concentration will be, mean corpuscular hemoglobin will be more. In only folic acid deficiency, without any iron deficiency, mean corpuscular hemoglobin will be more. That is more than 33 picograms, and mean corpuscular hemoglobin concentration will be normal because both of them are increased. MCV and MCH are increased. Serum iron will be normal and B12 will be low. So what are the maternal risks? Mother may present with severe anemia, pancytopenia, congestive cardiac failure, abruptio placenta, preterm delivery, cervical dysplasia, increased risk of postpartum hemorrhage. So what are the fetal risks? Fetal risks, there is high incidence of neural tube defects. Neural tube defects, what we see as spina bifida, cleft palate, cleft lip, meningocele, meningomyelocele. All these will might be present because of folate deficiency. Because CNS is the first system to be formed, and if the early stages of pregnancy, if there is pre-existing nutritional deficiency and folate deficiency, neural tube defects will be formed, and cleft lip and cleft palate might be present. If periconception folic acid levels are low, IUGR might be present, prematurity, increased perinatal mortality might be present. So what are the investigations? Mean corpuscular volume is more than 100, it is more. Mean corpuscular hemoglobin is more than 33 picograms, it is increased. MCHC is normal. In peripheral blood smear, what we see is macrocytic RBC and hypersegmented neutrophils. Hypersegmented neutrophils are the first thing to be seen on peripheral smear, and later macrocytes may be present. And serum folate level is decreased, that is less than 3 nanogram per ml. So how we treat folic acid deficiency? Oral folic acid tablet 1 milligram per day once might be to be given to every patient, and by 4 to 7 days improvement in reticulocyte is observed. It as is seen in our iron deficiency anemia, and improvement in leukocyte and thrombocyte count might also be increased. According to ACOG, every woman of reproductive age must be given 400 micrograms, that is 4 milligram of oral folic acid. So what are the additional supplementation of folic acid? What are the indications for additional supplementation of folic acid to be given? So 4 milligrams per day should be given in multiple pregnancy, alcoholism, alcoholism because liver diseases coexist, and folate is stored in the liver. So in alcoholism 4 milligram, and there will be pre-existing dietary deficiency. In alcoholism folic acid should be given, and in hemolytic anemia routine oral therapy it should be given. In Crohn's disease and inflammatory skin diseases, skin will be shed and epithelium will be shed, and iron and folic acid will be shed. And in Crohn's disease, because of poor absorption, it must be given. And in patients on anticonvulsants, they inhibit absorption of folic acid and they require more amount of folic acid. and previous baby with neural tube defects, cleft palate and cleft lip. Periconception folic acid reduces the recurrence of neural tube defects. So women with the previous history of neural tube defects should be given folic acid supplementation. So there are two conditions, that is prophylactic and therapeutic folic acid. In prophylaxis, we will give only 4 milligram of folic acid, and in therapeutic cases, therapeutic indications, that is in patient with previous baby with neural tube defects or cleft lip or cleft palate, we have to treat the patient. We have to give preconceptional counseling, and 5 milligram of folic acid should be given daily to the patient prior to conception. That is therapeutic. And prophylactic doses we will give to multiple gestation. In all these conditions, we will give 4 milligram of folic acid. Anyway, in our country at present, only 5 milligram is available. 4 milligram is not available. So routinely to every patient, we give only 5 milligram. So vitamin B12 deficiency, it is rare. It is rare and it develops over 3 to 4 years. So vitamin B12 deficiency is also rare in pregnancy. What are the high risk factors? That is vegetarian diet, patients vegetarian diet, and patients with gastrectomy. Vitamin B12 is not synthesized in our body. We are totally dependent upon the dietary source. So non-vegetarian diet is rich in vitamin B12 and it is poor in vegetarian diet. So vegans are high risk for vitamin B12 deficiency, and patients with gastrectomy, because it is absorbed, because intrinsic fat, the terminal ileum and stomach are necessary for the absorption of vitamin B12. So patients with gastrectomy, ileitis, ileal resection, and tropical sprue, Whipple's disease, and gluten enteropathy are at more risk. So patients where ileal disorders, term ileum is required, so where ileal disorders are present, they're at high risk of vitamin B12 deficiency. And pernicious anemia, Jollinger-Ellison syndrome, intestinal paresis, that is fish tapeworm, and it is confirmed by response to physiological dose of vitamin B12. So how we confirm is improvement with B12 supplementation. So what are the sources of vitamin B12? Humans are totally dependent on dietary B12. B12 is synthesized by the microorganisms in water, soil, and intestines, and B12 occurs in all animal tissues, no plant sources unless contaminated with bacteria. Minimal daily requirement in an adult is 2 microgram. Daily loss of B12 is 0.1% of the total pool of vitamin B12. So B12 is 3 to 4 milligram is the total pool. And when the size of the pool decreases daily, loss also decreases. Enterohepatic circulation helps to maintain the demand even with the diminished stores. 0.5 to 5 microgram excreted in the bile daily. Daily needed is 2 microgram per day. So daily B12 requirement is 2 microgram per day, and normal mixed diet provides 5 to 30 micrograms per day. Whereas in iron deficiency anemia, total body stores are 2.3 milligram per day, and what the average requirement is 4 milligram per day. So what is the interrelationship between cobalamin and folate metabolism? Excess of methylmalonyl-CoA and homocysteine occur in B12 deficiency. So in B12 deficiency, both methylmalonyl-CoA and homocysteine are increased. Only homocysteine is increased in folic acid deficiency. Only homocysteine is increased in folic acid deficiency, whereas both methylmalonyl-CoA and homocysteine are increased in B12 deficiency. A reduction in homocysteine levels in pregnancy and lack of a defined normal range for pregnancy may limit the utility of these lab tests. So what is the physiology? Homocysteine requires B12, that is vitamin B12, for the formation of methionine. Homocysteine converts into methionine with the help of vitamin B12 and methyl tetrahydrofolate. Both these are required for the conversion of homocysteine to methionine. So in case of B12 deficiency, homocysteine is increased along with this cofactor, that is methylmalonyl-CoA is also increased. But in tetrahydrofolate, for the formation of tetrahydrofolate, folic acid is required. So in tetrahydrofolic acid deficiency, only homocysteine is increased, not methylmalonyl. So hematological features of vitamin B12 and folate deficiency are, what we see is it is macrocytic anemia. Oval macrocytes are seen, hypersegmented neutrophils are seen, oval jolly bodies, thrombocytopenia, neutropenia, and red cell fragments and teardrop cells are seen. And both are same both have same smears and megaloblastic picture. Neuropathy may also occur in B12 deficiency. So how do we work up for anemia? So diagnostic workup is main, what we see is red blood cell indices, peripheral blood smear, and reticulocyte count. Mean corpuscular volume is usually altered. It is different for different anemias. If mean corpuscular volume is low, it is usually iron deficiency anemia. That is microcytic anemia. And if mean corpuscular volume is more than 94, that is megaloblastic anemia. 94 or 100, it is megaloblastic anemia. If mean corpuscular volume is 78 to 94, we have to exclude the other causes. That is, there is normocytic anemia. We have to exclude the other conditions like hemoglobinopathy, thalassemia, sickle cell disorders, aplastic anemias. Others should be ruled out. If it is low, iron deficiency. If it is high, megaloblastic. And if it is low, we have to do further investigations like serum iron. Serum iron is usually decreased, and total iron TIBC is usually increased, and serum ferritin is the storage form of ferritin. It is usually low. So serum iron and serum ferritin are decreased, and TIBC will be increased in iron deficiency anemia. Mean corpuscular volume is normal. Then we have to do reticulocyte count. Reticulocyte count, if it is increased, that is there is production of RBC because of decreased RBCs. So if it is RBCs are produced more in number, then it indicates that RBCs are less. So requirement is more. It occurs in hemolytic anemias and in hemoglobinopathies. Hemoglobinopathies are sickle cell anemia and beta thalassemia and alpha thalassemia. And if reticulocyte count is decreased, so MCV is normal, mean corpuscular volume is normal, but reticulocyte count is decreased. So bone marrow depression, RBCs are not formed. So reticulocyte count is also decreased. It occurs in drugs. It occurs in because of some drugs and diseases. Drugs are methotrexate and in other bone marrow disorders. Iron deficiency anemia in pregnancy. So how this is the just to manage, how do we manage if iron deficiency anemia, if the pregnancy is less than 30 weeks or 32 weeks and the patient is compliant to iron and iron improvement could be seen, and then we will give oral iron. So what are the oral iron forms available? Ferrous sulfate, succinate and gluconate are available. If the pregnancy is from 32 to 36 weeks or 30 to 36 weeks, will give parenteral iron. So what are the parenteral iron forms available? Iron sorbitol, dextran, iron sucrose, and also ferric carboxyl maltose. These are the 4 iron preparations available, of which iron sorbitol could be given only intramuscularly, and iron ferrous carboxyl maltose is usually given intravascularly, and other two, that is iron sucrose and iron dextran, could be given either intravascularly or intramuscularly, intravenously or intramuscularly. So what if pregnancy is more than 36 weeks? Since after giving iron, it takes 4 to 9 weeks for the hemoglobin to develop, hemoglobin to improve. So if pregnancy is more than 36 weeks, we don't have the time to improve hemoglobin. So we have to give directly blood transfusion is given, and exchange transfusion may be needed in case of congestive cardiac failure. So I will enlist this in next class also, because we didn't study thalassemias and chronic diseases, but just to compare, in iron deficiency anemia, serum iron is decreased, that is less than 30 microgram per ml, whereas in thalassemias there is defective hemoglobin formation, but iron is normal, so it is normal. And in chronic diseases, iron is decreased. TIBC, total iron binding capacity, since the iron requirement is increased in iron deficiency, so the iron receptors are increased, that is total iron binding capacity is increased to 400 micrograms. It is usually 35 to 50% saturated transferrin, but here transferrin saturation might increase. Transferrin saturation usually increases in sickle cell disorders because of heavy iron load, but here only TIBC is increased, capacity is increased, but because of less iron, transferrin saturation is also low. In thalassemias, TIBC is normal. In chronic diseases, it is decreased or normal. And transferrin saturation is decreased, that is 10% or less, because of low iron available in the body. And transferrin saturation is normal or increased because of in thalassemias, because iron load is also more. So serum also in thalassemia thalassemia, transferrin saturation is normal or increased, and it is normal or decreased in chronic diseases. And in serum ferritin is usually decreased. That is the storage form of iron. It is the first affected in stage 1 of the disease. In stage 1 of the disease, serum ferritin is lowered, and in stage 2 of the disease, serum iron is lowered, and stage 3 we will see the typical picture, that is hemoglobin is lowered, microcytosis occurs, and also hypochromasia occurs. And in serum ferritin is decreased, that is less than 30 micrograms, and it is serum ferritin is normal because iron stores are unaltered in thalassemia and chronic disease, and bone marrow iron is decreased or absent in iron deficiency anemia. They are normal in therapeutic test, that is response to iron. With if we give oral iron, there will be rise of hemoglobin, and there will be no rise in chronic diseases and in thalassemias. So thank you. In next class, we will be discussing the rest of the anemia, that is thalassemia, sickle cell disorders, and aplastic anemia. Thank you. If you have any questions, you can ask.